Thanks everybody for joining us for this session. We're really excited to introduce this new concept of mechanical preload reduction. This is something that we've been working on for probably about 15 years now, and we're going to see some really exciting data mechanistically as well as some of the scientific and clinical translation of this concept. To do this session, Jerry has thrown us a curveball, so we are going to do it in what's called a Pecha Kucha format. Dan was kind enough to just inform me that Pecha Kucha in Japanese means chit-chat. Chit-chat.
And we confirmed that with a few experts.
And we have a few Japanese experts who confirm that. So we're going to have a chit-chat. The way this format's going to work is we have 5 speakers who are going to present their slides in 7 minutes, and then at the end we'll have a discussion. So we're going to kick it off with our first speaker, Arvind Bhimaraj, who's coming to us from Houston Methodist. Arvind is the head of heart failure and transplant at that program, and he'll be talking about the principles of preload reduction and the pathophysiology.
Thank you. I hope all of you have smoked enough of the air that I'm told time slows down with marijuana. So let's see if the 20 seconds move on. But thank you to the organizers for this invitation to speak on this topic, and a special thanks to Dr. Curran for the time pressure he has created. Let's see how I respond to this preload pressure. The neglected concepts in heart failure physiology, like RV failure, have been recently revitalized. Similarly, the concepts of autonomic function and the interaction of autonomic dysfunction with preload is making a rebirth, as you will see in this session, followed by other speakers here. But the fundamental concepts of preload were described going down to the sarcomere of the heart. As a physiological concept, preload was initially described by Otto Frank and Ernest Starling in independent experiments, and this particular concept laid the foundation for us to understand preload. As depicted in these 2 figures, they concluded that more stretch pre-contraction leads to more force generation during contraction, and these 2 graphics associated with end diastolic volume on your right graphic actually lays that foundation for us. And this concept validated that dilation of the heart is not always pathological. The preload for an intact heart at an organ level can be depicted by EDV or EDP, and it is important to recognize, as reflected in these 3 pressure volume loops, that the preload can change cardiac output without any change in cardiac contractility, because you see that the ESPVR was the same. Now, for further clinical relevance, we need to recognize that depending on the ventricles reserve in an individual patient, the RV and LV can independently respond to their respective preloads, especially when we isolate the circulation with MCS. And it's important to imagine the heart as 2 pumps. The factors that determine this starting point, that is end diastolic volume of the PV loop, are essentially blood volume, vasculature, especially the veins, and the properties of the heart itself, like the ventricular stiffness, the leaky valves, and also the atrial properties. So preload can be controlled by various body factors that influence these determinants and then impact this important beginning point of the contraction. Now, heart failure is a syndrome that deranges many of these systems in the body, which you will hear in some of the later presentations, i.e. the kidney, the liver, autonomic system, and the splanchnic nerves. Blood volume is more accepted determinant of preload and is divided into the unstressed volume and the stressed volume. Most of the diuretics that we use are focused on the stressed volume, while the unstressed volume gives us an imaginative physiological concept, which is the minimal volume needed in the chamber. In this example, you'll notice that in the pressure volume loop of the LV, as you lower the stress blood volume of the LV, you see a drop in the cardiac output and the aortic pressure, which is contributed by the cardiac output. And note that it's not the afterload that's changing, because the width of the PV loop remains the same. Now, true to the wise monkey's words in Lion King, the interstitial compartment of volume expansion in heart failure is the hidden volume which can contribute to the unwanted preload of the heart during decompensation, and we need to think beyond what we see when we are devising therapeutic strategies to impact preload. And it is well recognized now that the kidneys play a major role in pathophysiology of preload control in chronic heart failure. The privilege to pee is compromised by the cardiorenal interactions, which are complex and still to be identified, as we've learned in some of the earlier presentations. One such understudied mechanism in my mind is a cardiorenal interaction of nerve receptors in the heart. But abundance of atrial and ventricular receptors were discovered in the 1970s in animal experiments, and further studies actually showed that you can modulate these receptors and increase urine flow, validating their role in cardiorenal interactions. Inability to respond to increased preload in pathological states can further worsen cardiac performance that can perpetuate the compensatory mechanisms like renal and autonomic nervous systems, worsening preload and finally ending up in an excess preload state in heart failure on the down arm of the Frank-Starling curve for the heart depicted in this graph. Also, the remodeling of the heart leads to an exhausted preload reserve, leading to lack of accommodation of the increased preload with a final increase of intracardiac pressures in the pathological state. And in this classic end-diastolic volume diagram, you can see the increase in pressures. The goal of this optimization, though, is to put the heart into an optivolemic state where efficiency of contraction is at its best, and you need some amount of preload for the ventricles which are dilated in a pathological state. Another under-recognized system in preload control are the veins, which are not mere conduits but can serve as large reservoirs of blood with almost 70% of total blood volume compared to only 30% in arteries. And the clamped state of these venous system can actually lose the reservoir capacity of the splanchnic system. And in this picture, you see the extent and the plethora of the splanchnic nervous system, and this dysregulated autonomic nervous system can impact the preload, and the clamped veins in the heart failure state reduces this venous capacitance, and hence we lose that venous system's ability to protect for unwanted increases in preload. Acknowledgement, discovery, and resurgence of preload as an important pathophysiological mechanism in heart failure syndrome has led to advancements in various therapeutic strategies, including one that we will focus on today on later talks, the PreCardia device, but various interventions relating to splanchnic nerve modulation have also been in place. With this, I hope I convinced you today that paying attention and staying awake to these series of talks highlighting the importance of preload in heart failure is worth your time. Thank you.
Thank you, Arvind. Wonderful. Okay, with that setting the stage, we're going to ask Manreet Kanwar to give the talk on acute decompensated heart failure and chronic heart failure and the role of preload.
Jerry, I thought Pecha Kucha was speak for Acute 2024 is in Tokyo, but I know there's another mission behind it. May I have my slides, please? There I am. So there's two kind of people in this audience today. Those whose liver is still unloaded from drinking last night and they didn't bother to do much about it. And those who went for an early morning run to unload their heart from what they drank last night. But they were able to do so by augmenting their cardiac output, their heart rate. But had they had a swan in them, they would have noted that their CVP, their PA pressures, and their wedge do not go up astronomically high as they do in heart failure patients when they try to exercise. This concept of preload reserve or dysregulated preload reserve in heart failure has been well explained as to how it results in central venous congestion as its primary presentation, as opposed to the opposite end of the spectrum, which is seen in POTS with decreased preload reserve as well. And these are patients who are ambulatory, compensated in the outpatient world. When they become decompensated and present to the hospital in this heart failure state, a whole new cascade of events happen, which we know very little about. Despite the fact that decompensated heart failure is the #1 cause of adult cardiovascular hospitalization, morbidity, and mortality, we still know very little about how to phenotype it, how to treat it, and how to make sure patients are sent home in a euvolemic state. Of course, when they're admitted with decompensated heart failure, we give them IV diuretics because that's what we know. And then our hospital police tells us it's the length of stay has exceeded. We need to send them home. And we continue to not be able to treat them effectively, something that has been an identified gap in the literature. And these patients, if you look at the data from ESCAPE trial, if you're sent home with a wedge pressure greater than 20, your risk of rehospitalization is going to be much higher. If your CVP is above 12 prior to discharge, your risk of rehospitalization from heart failure is going to be much higher. And sadly, 50% of these patients continue to be sent home still in a congested state of affairs, which is what brought them into the hospital to begin with. So the DRIPS data, the paper from Dr. Rosenblum in Circulation a few years ago presented at TCT, talked about how we can augment our pharmacological therapies with device therapies to have this concept of unloading using different mechanisms. And the two mechanisms that have been talked about a lot at TCT last year and THT are the pushers and the pullers. On this conversation and the talks to follow, we're going to obviously focus on a little bit on the pullers from the IVC filtration standpoint going forward. So one of the mechanisms of preload reduction, of course, is ultrafiltration, which has been studied in different mechanisms, be it aquapheresis, be it through peritoneal dialysis catheter. The idea is to remove isotonic fluid in an isometric fashion so that the renal perfusion is perfused throughout. But despite multiple attempts in understanding this as an augmented approach to IV diuresis, we continue to not be able to show this as an effective strategy in sending these patients home in a better congested fashion, as has been shown by both AVOID and CARESS heart failure trials. And in fact, stepped pharmacotherapy-based algorithm was shown to be superior to ultrafiltration. And when compared to the two of them, they had a very similar weight loss, regardless of whether they received ultrafiltration, which theoretically should have been more effective in getting them to be in a higher weight loss point at 96 hours after initiation. Which brings us to transcatheter-based therapies, which is a combination of be it intraarterial devices, pullers, pushers, as we were going to talk about. And again, the focus for today's discussions to follow will be the PreCardia device, but I'm also going to mention some passive IVC occlusion devices. The goal of all of this is, of course, volume removal with preservation of renal function as much as possible. So in HFpEF, this has been attempted, partial IVC occlusion in a first-in-human concept trial where invasive CPET was being done, and then the partial IVC occlusion happened during exercise in this patient population. And what they showed, that partial IVC occlusion led to rapid and significant reduction in PA pressures without reducing cardiac output or peak VO2. And they also noted that the respiratory rate for the comparator exercise capacity was actually better in those who had an IVC occlusion, leading up to the possibility that this may be a potential therapeutic option for patients who are admitted with decompensated heart failure in the setting of HFpEF. Similar concept, partial IVC occlusion using the Drya catheter. About 9 patients, first in human, published recently, showing that a 6 millimeter mercury drop in CVP was resulted in a significantly augmented diuretic response in this patient population with HFrEF. Similarly, the PTCR, again, this time in HFrEF patient population, about 6 patients reported significant reduction in filling pressures both on the right and left side using a partial IVC occlusion method in this proof of concept paper. Which brings us to the SVC occlusion, which Rayan is going to talk about in more detail, with the idea being that, again, active SVC occlusion partially that is done over a period of time resulted in significant improvement in CVP, urine output, and improvement in filling pressures. And the concept behind that is not different from what Arvind was just talking about, is working with our interventricular dependence, reducing the CVP, and kind of using the Frank-Starling mechanism, the downward shift, moving it back up to a more physiological shift, and thereby also augmenting the cardiac-renal syndrome that we're going to talk about, and improving the cardiac output and hence decongestion profiles. So we just, at my site, got activated. We haven't actually yet enrolled a patient, but we're really looking forward to getting up and running with the PreCardia at my center. And with that, I'll ask Rayan to continue to tell us a little bit more about their center's experience using the PreCardia device. Thank you.
Great, thanks, Manreet. It's a terrific summary. Next up is Rayan Yousefzai. He's one of the highest enrollers in the Venus HF study. And as a non-invasive heart failure specialist, he's also been the highest implanter of the device so far. So we'll hear from Rayan and his insights. Thanks, Rayan.
Thank you so much for the opportunity to talk. You have my slides? Okay. So the relationship between heart and kidneys are complex and through different pathways, including hemodynamic, neurohormonal, and autonomic system. The heart is directly depending on the regulation of salt and water content by the kidneys, and kidneys are directly depending on the blood flow and pressure generated by heart. Reduction in the renal blood flow in heart failure patient results in worsening GFR. Elevated central venous pressure is associated with decreasing renal blood flow. Initially, the kidneys try to preserve GFR by altering resistance of efferent and efferent arterioles. In worsening heart failure, this mechanism eventually fails. Worsening of renal function is associated with increasing mortality in heart failure patient. Elevated CVP is associated with worsening renal function independent on renal blood flow. Effective decongestion improves renal function, and it is associated with a better clinical outcome. We have to be cautious in interpreting the worsening renal function in patients with acute decompensated heart failure. In heart failure patient, the worsening renal function should be evaluated in the context of clinical status. In patients who respond adequately to diuretics and clinically improving, the overall outcome is better regardless of worsening renal function. However, about 60 to 80% of the patients who are admitted with acute decompensated heart failure do not achieve a complete decongestion at the time of discharge. The reason behind this are splenic congestion, reduced renal perfusion and filtration, cardiorenal dysregulation, and diuretic resistance with different mechanisms. Pharmacotherapy, for most part, have failed to show meaningful clinical benefits. The unmet need for treatment of the patient with acute decompensated heart failure is spurred an interest to developing a device therapy to decrease venous pressure, increase renal arterial flow, selectively vasodilate renal arteries, and remove excess fluid. One of these devices is a PreCardia system. PreCardia is a catheter-mounted balloon and pump designed to intermittently occlude the SVC. It's positioned above the SVC and RA junction and at least 2 centimeters distal to the tip of 10th French introducer sheath, as shown in this picture. In the distal tip of the PreCardia catheter is placed in the right and left pulmonary artery. The SVC balloon is inflated until a minimum of 10 millimeter mercury gradient between the right atrium and right internal jugular vein is achieved. A venogram is performed to confirm the occlusion of the SVC, as shown in this movie. The venous HF trial, the primary endpoint of the freedom from device and procedure-related major adverse event was met in all 30 patients. Compared to the baseline, the right atrial pressure decreased by 34%, pulmonary capillary wedge pressure decreased by 27%, and urine output increased by 130%. In a subgroup analysis of 13 patients who had a urine sodium data available, the urine sodium excretion measured by spot urine sodium and urine sodium over urine creatinine increased significantly with intermittent SVC occlusive. Interestingly, this increase persisted even 24 hours after device explantation. The increase in urine excretion was translated to increase in urine output and daily net fluid balance. Similarly, in this subgroup, the increase of the urine output persisted even 24 hours after device explantation, followed the same pattern as urine excretion. In our center experience, we have enrolled 13 patients to the PreCardia. All the cases were implanted, managed, and removed by a heart failure non-interventional cardiologist. The median age was 68-year-old, 62% were male, 92% had NYHA class 3, 8% NYHA class 4, and mean ejection fraction was 24%. The right atrial pressure and pulmonary capillary wedge pressure decreased in this cohort. Urine output was increased significantly and persisted 24 hours after device removal. On 90-day follow-up, there was 0% heart failure readmission and 8% total readmission for any reason. The urine excretion, the sodium excretion was measured by urine, the spot urine sodium, which was increased from 51 to 105 millicoulomb per liter. The BNP was decreased after 24-hour therapy. However, it was not statistically significant. And the sodium, the serum creatinine, and kidney function were stable. Some of the proposed mechanism, as was mentioned before, of action of the PreCardia include moving the volume to the more favorable place on the Frank-Starling curve, improving stroke volume based on interventricular interdependency, and decreasing renal vein impedance and increased renal perfusion by decreasing CVP, and also increasing urine sodium excretion. In order for us to understand the mechanism of action of the SVC occlusive device, we hypothesized that this device can affect the renal blood flow pattern. One of the parameters to evaluate the renal blood flow is arteriorenal resistance index, or RRI, which is calculated as shown here by the ultrasound. The RRI reflects the complex interplay between systemic circulation and renal circulation. RRI is affected by multiple factors, including pulse pressure, vascular compliance, vascular resistance, heart rate, interstitial pressure, and renal blood flow. RRI has prognostic value independent of GFR. The renal venous impedance index, or VII, assesses the renal venous pattern and is as a measure of the vein pulsatility. The high renal venous pressure would cause congestion of the peritubular and glomerular capillaries, reducing the arteriovenous gradient and thereby impairing renal blood flow. We hypothesized that the PreCardia improves the overall perfusion of the kidney by modifying the arterial and venous flow pattern and decreasing the central venous pressure. It can also modify modulates neurohormonal pathway and urine electrolyte excretion. The final outcome is more effective response to diuretics. In conclusion, the cardiorenal interaction is complex. The pathways are hemodynamic, neurohormonal, and autonomic. There has been a significant interest in device therapy in the acute decompensated heart failure domain, and there's a need and call for further understanding of the mechanism of these devices and implementing them in our clinical practice. Thank you so much for listening.
Okay, the final talk in this session before we have our discussion will be from Harrison Farber from Tufts, and talk about acute right heart failure and pulmonary hypertension.
Okay, so thanks for inviting me.
Okay, you're going to go. You have to give the last talk.
Okay, so we're going to talk about acute right heart failure and pulmonary hypertension. So basically, these are the current classifications of pulmonary hypertension. We're not going to go into them, but the bottom line is any way you get pulmonary hypertension, eventually you can get right heart failure from it. Group 2, which is pulmonary hypertension from left heart disease, is far and away the most common in the Western world. So pulmonary hypertension, if you start out with a normal vessel, things happen. And then you get vascular injury and eventually disease progression. Ultimately, you get a vessel that isn't at all reminiscent of what you started with. So it's thickened, it's hypertrophied, you get plexiform lesions, you get proliferation, such that your right ventricle now has to pump against something that it's never been was meant to pump against before. So on the top, as you see, as the pathology progresses, the cardiac output drops, the pulmonary artery pressure drops, and the PVR starts to go up, leading to right ventricular dysfunction, dependent upon how rapidly it is and how well your right ventricle can compensate. That, along with everything else, leads to change in functional characteristics. And at the bottom, you see that as this progresses, your New York Heart Association functional class decreases to eventually a functional class 4. Most people present in at least functional class 2 or 3. And then you have all the signs of decompensated pulmonary hypertension, which we're all used to seeing: shortness of breath, edema, et cetera, et cetera. Now, eventually, through this incredibly complicated slide, which multiple pieces have been shown, you develop right heart failure, right ventricular dysfunction, from pulmonary hypertension, which has multiple different pathways to get to the same point. That's what makes it so complicated. Even if you try to dumb it down a little, which for me, that's all I can do, is you still end up with right heart failure from multiple different causes, okay? And that's part of the problem. It is not very homogeneous at all. So now you have right heart failure. What do you do? So from your pulmonary hypertension, right heart failure, there's sort of 5 sort of principles as to what you try to do to reverse this, stabilize it, or improve it. So first is obviously try to treat the cause of RV failure. Most commonly, it's due to left heart disease. Left heart failure or left heart disease is the most common cause of right ventricular failure in the Western world, associated with myocardial ischemia. Then you have pulmonary hypertension and pulmonary embolic disease and other rarer forms of pulmonary vascular disease. So you want to optimize RV preload because most RV failure is caused by, associated with, or aggravated by volume overload. So you optimize that either with diuretics or CVVH ultrafiltration. Then you want to try and reduce the RV afterload to make your RV work better, bring it more up to a Starling curve. So obviously left heart disease, try and treat whatever the particular entity is. For precapillary pulmonary hypertension, which is what I do, you need systemic prostanoids, either epoprostenol or treprostinil, which we can get into a discussion, okay? You want to support the RV contractility, so vasopressors, inotropes. You want to restore any arrhythmia that you have, especially tachycardia or bradycardia, because RV does not function well when its rhythm isn't good. And you want to have some sort of map. There are some recent studies to show that a variable map might actually be better than a set map. And then you get mechanical circulatory support. These are the things that have been used in right heart failure from any form of pulmonary hypertension. Now, all that said, we still don't do that well at all. The death rate from pulmonary hypertension or RV failure is huge. So we're looking at PreCardia here as potentially a way to do this. And why? Well, it's interesting because in this venous heart failure study, which has been quoted multiple times, it's interesting because aside from obviously getting rid of congestion, it's noted that this SVC occlusion actually decreases mean pulmonary artery pressure, actually almost by half. And obviously that would be huge, potentially, to decrease some degree of afterload. What's interesting is the cardiac index does not change with this, okay? So that your right ventricle actually still is sort of the same, but now it's pumping against less of an afterload, so it may have time to recover. And this is important because a lot of this, like institution of systemic prostanoids, takes a while to do. So, interestingly, maybe you could use the PreCardia in precapillary pulmonary hypertension alone and help people with decompensated heart failure from pulmonary hypertension until you can buy time to institute other therapies. That's it. Thank you. I don't have a chair.
You got my chair.
I'll take your chair.
You got my chair. Absolutely.
Thank you, Harrison. Okay, and now the last talk before the discussion will be from Navin Kapur, who's going to talk about the PrePella 1 study.
Great. Thanks, Dan. And thanks, everybody, for listening to the session. So I'm going to be talking about PrePella. So we've heard about ECPella. Now we're going to introduce PrePella, a novel approach to maximize cardiac unloading and recovery. So I think it's important to recognize that all pumps, natural or man-made, are preload dependent. Every pump requires a certain amount of volume coming into it and has to pump against a certain amount of afterload. So these are fundamental physiologic principles that we're trying to target with these technologies targeting preload. One of the things that I think will become evident is that when we start to look at pump function, we learn a lot from the surgeons and from the LVAD space. In the LVAD space, all of these technologies are preload dependent. When we see bleeding, when we see hypovolemia from any cause, we start to see more ventricular arterial uncoupling as the LVAD starts to source that volume from the LV and starts to evacuate that volume. Now, this is myself relaxing after Acure, but for anybody who lifts weights, I think it's important to recognize that the strain phase of the Valsalva maneuver reduces total cardiac preload. And when you have an LVAD in place where you can look at the waveforms, during that reduced preload, you see maximized ventricular arterial uncoupling. And so the question is, can you start to harness this ability to regulate preload? We also see that with Impella. The most common scenario we see that is with RV failure. RV failure reduces LV preload. If you have an Impella sitting in the LV, you can start to evacuate all of that volume and lead to profound VA uncoupling. And that's, of course, the trigger for why we use right-sided support in those cases, because that's the cause of the reduced LV preload. So the holy grail for all mechanical support devices is to unload, hence Acure, and that means reduce pressure volume area. On the left, you see the left atrial sourcing, so that directly reduces LV preload. And on the right, you see direct LV sourcing with the CP versus the 5.5. The 5.5 really getting to maximal LV unloading that can be achieved with a transvalvular pump. So we introduced this concept of SVC occlusion. We note that in contrast to IVC occlusion, SVC occlusion decreases LV preload, but it doesn't trigger any hypotension. The systolic points on the LV pressure tracing are stable, but we see a nice reduction in LV EDP and an increase in LV capacitance and LV stroke volume. So the PrePella concept combines now PreCardia with Impella to control preload and afterload, those two cornerstones of cardiac function, and thereby achieve maximal unloading by using these two technologies together in concert. So I think the idea now is that as we start to mechanically harvest this, we have to start to test it in preclinical models. So in a preclinical model of acute MI, acute LV dysfunction, we wanted to quantify the acute hemodynamic effects of SVC occlusion and Impella activation. You can see on the left our preclinical model by Laura Rayan, basically using PreCardia, the SVC balloon, right next to the Impella, but now in the venous system as well as in the aorta, and of course with PA catheters and conductance catheters. We know that the Impella CP itself will actively and rapidly reduce LV PVA. You can see at P9 in this acute MI model already a shift and a reduction in LV PVA, especially with the volumetric shift in the green dots going towards the left. So this is what we understand as canonical unloading with an Impella CP. In this preclinical model, when we quantify that amount of effect, you can see that going from P3 to P9, there's about a 25% reduction in this non-shock model, but an acute model of LV dysfunction. And I think that's a pretty consistent effect we've seen over the years with an Impella CP at P9. So the question now is if you could regulate the preload coming into the Impella, what would happen? So PreCardia activation with SVC occlusion further reduces PVA on Impella support. You can see that on the right with the P9 at SVC open compared to SVC closed, there's now an even more profound shift going towards the left with a reduction in pressure and volume, starting to look beginning like a 5.5 level amount of unloading. And when we quantify the incremental effect of SVC occlusion on top of Impella support, we can see there's an additional 30% of PVA reduction when you combine the two technologies. And when you compare that to no pump, there's a 45% reduction. Almost half the PVA is now taken away when you combine preload and afterload augmentation or reduction using two technologies. In these studies, we are starting to see significant reduction in LV end diastolic pressure with the combination as well as LV end diastolic volume. Importantly, we're starting to now see that VA uncoupling, a stable arterial pressure, minimal pulsatility, but the map is stabilized by the Impella, and you start to see that maximal LV unloading with the LV pressure points coming down. Now, in these videos, what you can see on the left is a dilated ventricle. This is a typical pre-5.5 patient, and then post-5.5, and that's the echocardiographic evidence of PVA reduction. So you can see the 5.5 loop compared to the CP and PreCardia or PrePella loop, and they start to look like each other. And I think that's really the idea is can you get these smaller bore devices to give us better unloading? So PrePella may actually now attenuate hemolysis that we see when you're running a CP at P8 or P9 for days. That's where you start to see the propensity towards hemolysis. But if you could get the RPM to reduce down into the P5, P6 range, but still achieve that LV unloading goal, this could be now done by combining the two. And as you heard from Hap, there's some exciting work being done in the right ventricle. So in these dilated RV decompensated patients, they're also preload dependent. We know that SVC occlusion can also start to unload the right heart. And so the question is, can you combine these two technologies for right-sided support? And the idea here is that if you're able to especially use that SVC axis, using the PreCardia, for example, with a catheter on a PA catheter-mounted approach, versus the RP, where you're also traversing, especially with the RP flex, through the SVC. Can you now start to enhance renal perfusion, diuresis, and recovery by maximally unloading the venous system using a combination of right-sided pump as well as SVC occlusion? Now, the exciting field going forward is we're going to get more into small bore transvalvular pump technologies, and the idea now is to use PrePella potentially to maximize the effect of the smaller bore pumps to now get to those levels of PVA reduction that you might see with larger bore pumps, but without the need for that larger arterial access. And I think that's where the future is headed. Now we have the opportunity to mechanically regulate preload, afterload, and contractility, the three cornerstones of heart failure management. And the combination of PreCardia with any Impella technology, I think, is ripe for an investigator-initiated study to use the technology and study these acute hemodynamic effects now in the clinical setting. So thanks very much for your attention. And we'll open it for discussion.
Okay, I think we have now about 10 minutes, 9 minutes for discussion. And yeah, Patrick.
The two organs we want to preserve for long-term outcome is the brain and the heart. So we have learned a lot about heart hemodynamics. What is the impact of the PreCardia device on cerebral perfusion? Is there the expected venous pressure increase and the decrease of cerebral perfusion?
Yeah, this was a really important question, was what is the effect on the brain with SVC occlusion? So in the venous HF early feasibility study, the first round of patients was exquisitely focused on neurologic safety. So in fact, a neurologist was at the bedside throughout the 24 hours of pumping period, monitoring the patients, and we saw no effect on neurologic capacity. These patients are awake, they're interacting like they are normally, they're eating and engaging. Now, in our preclinical models, we've gone further. We've now put pressure and flow wires up into the middle cerebral artery, into the intracranial space, and we see that there's very nice autoregulation of blood flow through the brain to the point where venous increases by even 20 or 30 millimeters of mercury does not affect renal or cerebral perfusion. This is also something we've really heavily vetted with our neurosurgeons and our vascular surgeons to understand, especially spinal effects and intracranial effects. And from their perspective, the autoregulatory effects of intracranial pressure are pretty profound and not directly affected as far as we've seen. And that's the purpose of the EFS study.
Any questions, additional questions from the Kenji?
What's the impact of this inflation on sympathetic nerve activation?
Yeah.
Because there are rich in receptors. If you inflate, then I would expect you block the sympathetic nervous system, which may result in severe dynamics.
Correct. So in fact, I think...
Repeat the question.
Yeah, so let me repeat the question. So the question from Kenji was, what is the effect of the SVC balloon being inflated in that position? Does it cause stretch of the SVC? And does that trigger a neuromodulatory effect that might be triggering the diuresis? And I think Arvind showed really nicely that is likely what is happening, especially on the renal side. The study that he quoted from December 1973 was one of the first studies to basically look at SVC stretch independent of a hemodynamic effect. And what they showed was there was a direct effect on increased diuresis with SVC stretch. They measured in 1973 C-natriuretic peptide in the urine, which is again released in the setting of neurohormonal stimulation. And what they found was increased levels, again suggesting that the prompt diuresis we see may be related more to stretch, not only just due to hemodynamic unloading of the renal vein. Yeah.
Did you observe change in heart rate when you inflate the balloon?
Yeah, we've been looking very carefully, and I would say in a very blunt way, at heart rate. We haven't looked at heart rate variability. We haven't looked at beat-to-beat variation, but we don't see a significant change in heart rate until the patient diureses and starts to come out of a decompensated state. But we haven't seen that acute effect on heart rate as a blunt tool, but heart rate variability still remains open. And I'll ask Rayan to comment on that in terms of his experience clinically. Rayan, do you want to describe what you've seen in your patients with SVC in terms of their heart rate or urine output? What are you seeing at the bedside?
Yeah, I think we have a kind of mix of patients. I think some of the patients. That's one of the things. I think the next step would be to understand a little bit better who are the right people. That they respond to PreCardia. We had some of the patients had a huge response after putting a PreCardia. Some of them not as much. As far as the clinically, really, I haven't had of the patient we enrolled. I haven't had any issue with as far as the neurological changes or any SVC syndrome type of that people are worried about. And as Navin said, as the heart rate variability, nothing significant I have noticed, but there are some patients that they come with the acutely decompensated, they're more tachycardic after they're getting diuresed and getting through that decongestion, their heart rate actually improves within like a 24 hours. But I haven't looked specifically beat by beat variability and between during the inflation or deflation of the balloon. But generally, trend has been toward decreasing the heart rate in some of the patients.
More questions from the...
Yeah, Jakob Hauser, Janssen Pharma. I was wondering if you see any cases of loading via the Asiga system. If you're going to enroll patients with PAH, you might have some in there with the history of CHD, abnormal anatomy. Is that an issue at all?
Yeah, I think the question was about the Asigas. Is that what you're asking? Yeah, so
Correct.
The question is about the Asigas system and how is that affected by SVC occlusion. It's still an open question. I think in the video that Rayan and Arvind showed, you can actually see at the very end the Asigas filling with that SVC occlusion and the contrast injection. We don't actually know the answer to that just yet. I think we're just beginning to understand. And in fact, balloon position in the SVC is also something that needs to be optimized. Is it better to occlude the Asigas, or is it better to actually sit below it? My theory is that it's better to sit below the Asigas, allow it to remain as a pop-off valve to make sure that we don't get excessive pressure overload above the balloon.
I just wanted to know how long that you occlude the vein and what the experience is with the length of...
Yeah, the duration of occlusion is the question. And so in the venous HF study, we studied 5 minutes of occlusion with periodic deflation of the balloon. Having said that, what we're also learning is that that's probably an artificial number. And in fact, the astounding observation we're seeing preclinically is that you can leave the balloon occluded for hours. And there's really, really no neurologic effect that we're identifying. We've done a lot of the autopsy sections on the brains, looking at eyeballs, et cetera, to make sure there's no evidence of edema or anything like that. And so I think as we move forward, we know that there are technologies that are used for SVC occlusion for a prolonged period of time, especially in bleeding. The PreCardia device has also received now a 510(k) approval. So we're excited to test the idea of 30 minutes or longer where you can manually deflate. And I think that's what, again, makes it very nice for an investigator-initiated study in the operating room with a 5.5, inflate the SVC balloon, assess all the hemodynamics while you're occluded, and basically make sure the patient's doing well. But duration, I think, is still an open question. We think that you can go much longer than 30 minutes.
Navin, I have a question for HAP. HAP, the idea of using this in precapillary pH is quite interesting. Do you have any clinical experience using this device in patients with PAH? Has that been done? And do you see acute changes in LV filling with inflation of the device?
Unfortunately, so far the answer is no. We're still waiting for IRB approval to use it, but I think, at least my gestalt is that it probably will work. It probably will improve LV function because by improving RV, you're going to move the septum back over. So the question will be is, realistically, I see it more for pulmonary hypertension as a way to buy time so you can do all the other things you would normally do, whether it's pulmonary hypertension from just true PAH or from, group 4 from thrombotic disease. But no, not yet. Close. Wait till next meeting. We'll have data.
Is there a minimum right atrial pressure or some other characteristic you're going to use to?
Yeah, so the defining characteristics that we're going to use is that you're going to have a cardiac index of less than 2, okay? And RA pressure, we haven't really decided between 15 or 20, but somewhere in that to start with, and a PVR of greater than 5 Woods units. So you start out with somebody who all of us who do pulmonary hypertension for a living would have no argument that they are in right heart failure.
Thank you.
Is there any other questions from here? One of the principles of this is that reducing preload to the heart doesn't decrease cardiac output. And, we had some, Arvind, you talked a little bit about this. Would the same principle apply for the RV? Do we know about the descending limb of the RV Starling curve?
Well, it's interesting in that if you look at the venous heart failure stuff, when they blow up the balloon, the cardiac output doesn't change. And you're measuring cardiac output, obviously what you're really measuring is right ventricular output. So why it doesn't change, though, I think is fascinating to me. I'm not sure why it doesn't change. And it may be it doesn't change because by the drop in the preload, you actually improve the contractility of the RV because it's not stretched as much. And it's clear that in an RV, the more it stretches, the worse its contractility, and then obviously its cardiac output is going to be. It's also clear that if you can decrease the preload, forget the SVC balloon thing here, though. If you decrease the preload of an RV in general, in most cases, the cardiac output will either stay the same or go up, unless you obviously drugs to improve it. But it also depends probably, which is going to be very heterogeneous, on how damaged or how stretched or how adapted your right ventricle is before all of this happened, okay? Because there are people clearly who go into right heart failure, we'll call it subacute versus truly acute. So those people don't necessarily dilate as much. They maintain their cardiac output, and you don't have to take a lot of volume off for them to recover. These people have an acute change in their right ventricular distensibility and then contractility, say from a massive PE, and they dilate, those people are in trouble because you have to change their preload dramatically and decrease their afterload dramatically in order for their right ventricle to recover. So I think part of the problem is you're going to, at first it's going to be hard because just like everything else you guys talk about, this is not a homogeneous system. And it may be that in certain people, this balloon occlusion is going to be better, okay? And that there are people you can rescue and people you can't, but we'll find that out.
I think it'll be interesting. The physiology may be different between the chronic heart failure and the PAH.
Absolutely it is. Because, I mean, for the longest time, we thought the right ventricle and the left ventricle worked the same way, which of course they don't. They're not even from the same embryonic tissue. So to expect that they would actually work the same, not going to happen. So that the responses of the two ventricles, I think, to this whole system are going to be very different.
Hap, do you think there's a refractory precapillary pH population where,
oh, absolutely,
as you like to call it, you give them the juice,
well,
and the juice doesn't work?
Well, currently the answer is yes, but
the juice being pulmonary vasodilators,
like epoprostenol. The answer is yes, but there's a but to this, and part of the but is we do have that, but if we could buy more time.
Yeah.
Okay, so we had more time to institute these vasodilators and to get them to what we would consider a more appropriate therapeutic dose, then maybe there isn't a but anymore. But we don't know that yet, and maybe this would help to find that out.
Yeah. George, you have a question?
Yeah, quick question. For years, we've dealt with right ventricular infarction, acute and even subacute. And we've always treated it just by pushing volume on it to get through it, turn it into a conduit. Are we doing the wrong thing? And how does this, should we be doing something different?
It's a good question, actually.
Well, there you have a different situation.
It's a different situation because the right ventricle is now ischemic.
I understand, but maybe we're doing the wrong thing to
since
recover.
Cardiologists always do the wrong thing. I'm not only kidding. I think it's a very different. George, it's a very different pathophysiology. I think I would take that group of people out of all of this.
So look, with RV infarct,
no, because the big difference is
you got to fill the LV.
The big difference is, okay, stop for not kidding around. The big difference is you don't have a huge afterload to the right ventricle when you have an RV infarct. Okay, and all of these that we're talking about are due to a change in afterload and change to what the right ventricle has to pump against. Okay, so that group of patients is probably different and probably should be subtracted from this discussion.
But I do think even in that group, we've learned that there's an upper limit for the volume resuscitation, right? So that comes to the optimal stretch you need. We tend to overdo sometimes where just giving volume until we realize you need an MCS for those patients.
Yeah, and I think Manreet and Arvind, maybe you guys can comment on the effect of Impella 5.5 on right-sided hemodynamics and this idea of PrePella. So is this a foreign concept to you? Do you think it's physiologically sound at this early stage of this disruptive concept?
So I can say, when we first started using 5.5, we were worried about the fact that these patients are going to need to be mechanically ventilated, they're sedated. Is it going to take a hit on the RV? Are they going to need an RV unloading device in addition to the LV unloading device? But in reality, I'm yet to actually see that happen. So I think once you effectively unload the LV, the RV follows. You just have to make sure they're not supremely decompensated from an RV standpoint, and that you're ready to proceed with VA, ECMO, et cetera, if the RV were to give in as you're trying to go in for a 5.5. So I think it's a very effective unloading strategy because the number one cause of RV failure there is LV failure. So you unload the LV, you unload the RV.
So is there an RA pressure that you guys get concerned about, the RV not
Concerned,
doing well
yes, but
with the
not
5.5?
actually, it hasn't led us to not do.
So what's your
have that
RA
strategy.
cutoff for concern?
Again, if it's more than 15, 18, I would worry about it. But I'm yet to actually see somebody not come out of it at 5.5, but we always worry about it.
Yeah.
Yeah, I do think I've seen people kind of not be mindful of appropriately adjusting your 5.5 flows for the RV, because we've had few situations where it's a test of VADs, right? You put in an Impella and then your RV fails. I think in those patients, there might be a role of this PrePella concept. And all I can say is I agreed with her. She leaned over after your presentation and said, every 22nd of your slide was more meaningful than any of our 20 seconds. So I think it's a fascinating concept of optimizing preload to increase your efficiency of your pump. I think it is amazing.
Patrick.
To get more physiologic insight on the difference between just bleeding a patient by a few hundred milliliters compared to blocking the inflow to the right ventricle. Because for the heart, this may look similar, but for the venous system, it may look different. Have you any comparison, any insight, any data on that? Because we know in ECMO patient, the early effect of ECMO includes bleeding 500 milliliters into the ECMO circuit. And so how about bleeding as a cheaper approach to reduce preload?
So from a healthcare economics perspective, we might consider bleeding a very expensive proposition for preload reduction. But there's no doubt that obviously I think this is what gets into the stressed and unstressed blood volume state. If you rapidly reduce the stressed blood volume state by bleeding and hemorrhage, that's going to be a very challenging situation for preload reduction to manage that.
But is there a difference in the physiologies of using a device to reduce preload and just changing the blood volume to reduce?
Well, reducing total circulating volume with bleeding is going to activate sympathetic tone. Yes. You're going to get a very hyperadrenergic state. That's exactly the opposite of, I think, when you start to mechanically regulate preload. And that's really the idea here, right, is that we don't have methods where you can fine-tune preload control. And that's what the NPR session really starts to introduce, is fine-tune preload control.
Well, I think that there's something, I think we should totally discount it because, to change effective like CVP and wedge, you don't actually need to have huge changes in stress blood volume.
Yeah.
Probably in the range of 250 to 500 is probably all you need. So would not be a huge amount of bloodletting, but nevertheless, I'm not sure that that's the right way to go. Probably keep the blood inside the body instead of taking it out of the body. Chris, well, I think we have time for one last question, unless George says no.
Patrick's approach could have save the shortage of red blood cells for trauma patients. But I think preload reduction is also one of the reasons why VA ECMO in patients with decompensated heart failure is hugely advantageous at the early phase. Because I think it's not the perfusion benefit of VA ECMO, but the preload reduction, so unpreloading. So it's not primarily a loading device at that stage. But through preload reduction, you help the heart at that early phase in VA ECMO, right?
Yeah, I think depending on your preload volume, how much capacitance you're dealing with, there's no question that if you have an RA pressure of 2 or 3, you activate VA ECMO, you can reduce total cardiac preload. You'll do that at the expense of potentially increasing the afterload and then the systemic inflammatory effect of the oxygenator. So it's what we're learning, and I think you'll see that in the PrePella literature that's coming out and probably see it at ESC within 48 hours, is that VA ECMO really starts to have a profound effect that's almost independent of hemodynamics. And that's where I think it starts to get much more complicated. The idea is to create a simple maneuver that doesn't have this huge systemic effect that VA ECMO has. Yeah, but principle is correct.
Well, let's give a big round of applause. This group has done a wonderful job.